So welcome everybody to our webinar this morning, which is all about sharing the learning from our Improving Transition for Young People programme. So a very exciting morning for us. I'm going to do just a little bit of housekeeping at the beginning, just to let you know a few things. One is that all of our participants this morning, so all of our delegates this morning, you'll be on mute with your cameras off, just to let you know that. So if you have anything you want to share with each other or introduce yourselves, that kind of thing, do put comments into the chat function. If you have questions for any speakers as we go along, if you could use the Q&A function, which is at the bottom of your screen, just pop them in there and we'll try and address those as we go along. But we've also got time at the end of the programme for some panel discussion and questions then as well. Just to also let you know that we will circulate the slides from today, so those will be coming out to you. And also to let you know that we'll be sending out an evaluation form at the end of the webinar. So if you would kindly fill that in for us, that would be really helpful. So I think that's everything in terms of housekeeping. I'm going to hand over to our chair for the morning, who is Professor Sir Alan Craft, who many of you will know. So Sir Alan is the president of Together for Short Lives, and also he was the chair of our interview panel for the transition programme. So from the very outset was very involved in this programme, and he's kindly offered to come and chair our morning for us. So I'm going to hand over to Sir Alan.
Good morning.
Good morning.
What am I here? Is that all right?
Yes, we can see you and hear you.
Lovely. Right. Well, welcome to everybody. There are currently 71 people on this, or 72 now, which is an excellent number of people for what is a very important webinar for us. I'll just say a few words of introduction. My professional life was as a paediatrician, and then I became involved in Together for Short Lives. And it's always been known that the transition from the care of children to the care of adults, can be difficult. It first came to light with things like renal transplants and diabetes, where the care went wrong. I mean, children were well looked after by paediatricians, and then they were cast out into the big world of adult medicine. And things, for transplants, the transplants often rejected, and diabetes went wrong. And it's only a little bit later on, in evolution, that we began to see the same thing, that we as professionals began to see the same thing in children with life-limiting conditions. That's not to say that there weren't always big problems, because parents will tell us that. And Sue, a little bit later on, is going to tell us about her experience. But we know that not only do medical things happen, but in particular, the trauma, the anticipation and the trauma of getting to what parents say, is this cliff edge that we are about to fall off. What do we do when the paediatricians, who tend to look after children very well, probably too well, or certainly in the past it's been too well, in terms of not giving them, not giving children and parents the wings to fly into the adult world. So we've become very aware of the needs of children, young people and their families in getting from the cosseted world of pediatrics into the somewhat harsher world of adult life. And for the past few years, we have had a task force on transition, which is set up in each region, separate task forces. And I think things have improved a bit. But what we have learned, I mean, David Strudley, I don't know whether he's on the call today, but David Strudley chaired our transition working party. And what it did was to raise as many questions as it did provide answers. And several years ago, we were fortunate that we had 3 funders who agreed to fund this program of work that you're going to hear about today. And I may not have time to thank them later in the day. So we're extremely grateful to the 3 funders who put a really substantial amount of money in to these projects that you're going to hear about today. And what we tried to do when we were setting up the program, we had a lot of projects to choose from. We tried to look at what David Studley and his task force had come up with in the sort of broad areas that we needed to look at. And we tried to choose a whole lot of projects which were complementary. Most of them were quite different. They were either different in substance or they were different in different settings. And I think that what we've got is some really good information on what young people and their families want and what they need. Not only do we know what they want and what they need, but we've actually come up with some solutions as to how we might improve things. So what we're going to do is to hear from several speakers today about various of these projects. There's a slight change to the program in that you'll see at the bottom of the program, we've got Gareth Jones and Louise Porter from the NHS. Unfortunately, they have to be away by 12:15. So we're going to put them slightly further up the program, and we're going to have the Q&A session at the bottom. And in particular, I would like you to think of, if we've got any questions for the NHS people, we'll give those priority because they will be leaving us. I'm sure the technology is going to work wonderfully. This is the first time I've chaired one of these webinars on Zoom, so you'll have to forgive me if I get things wrong, but I've got some good minders Together for Short Lives who have got total control of the day, and they will put people in, put people out. Right, oh, we're getting questions already or comments. Right, thank you. So without more ado, let's get started on this important session. The first thing we're going to do is to hear what it is really like to be a parent. Sue Ben-Abrahams has been through this whole it's not an exercise, a whole bit of her life where she had a young person with a life-limiting condition. And she's now going to tell us about that and perhaps give us some ideas as to the sort of things that we should be thinking about doing for the future. So Sue, there we are. We can see you beautifully. The lighting is perfect.
Yes, my bedroom. Yeah.
It's amazing. So, Sue, over to you. Tell us your story.
Thank you, Sir Alan. So my name is Sue Ben-Abraham, and my late daughter and I were very much part of the Together for Short Lives community since the launch in 2011. So back in 2018, Julia Hodgson invited me to join the Together for Short Lives funding panel, which Sir Alan has just mentioned, for improving transition for young people. And amongst the many bids was the Expert Parent Programme. It was from the Disabled Children's Council. It was successful in its bid. And it was a programme that offered parents such as myself the opportunity to develop skills and knowledge in terms of having to transition their adult child into adult services. It informed on legal rights, best interest decisions, what to expect from adult services and adult hospitals and wards, use of language and terminology that we were never familiar with, and actually finding the confidence to negotiate with professionals. And mostly what it did is gave you the toolbox that you needed to secure a smooth, safe transition into adult services. By that time, it was a case for me and my daughter that if only I'd known then, you know, what I soon learned some years down the line, things may have been quite different. So personally, I can really vouch for the Together for Short Lives expert parent program. Not only did I become an expert parent facilitator, but I was able to contribute to the development of the program, as I said, from my experience of going through the transition with my daughter Simone. So a little bit about the transition, Simone lived at home until she was 14. I looked after her. We had a direct payments package, and it went pretty smoothly. And we were very, very, very well cared for by paediatricians at the local hospital, and we were very well known. So at this point, 14, 15, no formal meetings or discussions had taken place about transition. It was just this sort of word that got bandied around, sort of like a slightly scary word that something might happen in the future. But as a parent, I just thought that would never be possible. So then Simone moved full time into her school placement, residential school. She was coming up for about 15. And they also provided an adult service. So it was, for some years, it was naturally thought that Simone would automatically transfer or transition into their adult services. It just transpired that actually it didn't work that way. So I put, unfortunately, this was not the case. And what ensued was incredibly complicated, stressful, and unexpected. Simone had literally slipped off the radar, and it was a looked after nurse who called one day and said, "Have you begun transition talks?" And I said, "Well, no, I think she's going to go to the adult services." And she said, "Well, it doesn't actually work that way. We need to have meetings and we need to talk about options," which is a horrifically scary word for most parents, especially when you've been so well looked after for so many years. But options was something that you might have no control over, and that other people were making decisions on your behalf of what your child where she may end up. So also, it's just very important to know that the provider that she was with at the time was very instrumental in ensuring that she stayed with them. She was worth, nevertheless, quite a lot to their trust. She didn't, you know, she came in at quite a lot of money. They were very instrumental in ensuring that she stayed with them. So she was offered a place at the adult services, at the provider that she was, who was currently in the children's services, but unknown to me that it was only a provisional offer. I always thought that she was secured there and that that's where she'd go. Then various things happened, and I decided I wanted Simone to come back into the community, out of care, and back into a home with me. So I was very successful in securing a fully adapted, rather lovely 3-bedroom property nearby through a housing association. And I put together a team of excellent carers who knew us very well. And we had 2 nurses on board. And I said, well, my option is for Simone to come back into the community and live with me again. And then all merry hell broke out. It really did. I put the resistance to this transition came from all directions. There were people at the local authority that did not agree with it and were not going to participate in it. There was the CCG, 2 nurses in particular, put so many obstacles in our way in terms of keeping Simone safe in the community. Please bear in mind that I'd already looked after her for the first 14, 15 years with carers. And the provider, once again, putting as many obstacles as they could in my way, in our way, to move Simone into this property. So what happened was, due to, as the lawyer that I later took the case on, he said that they had become the most unlikely bedfellows. That would be the CCG, the local authority, and the provider. And they closed ranks on us, basically. So And he also said they've certainly put a lot of obstacles in your way. So the reason being that Simone, the overarching reason being, their reason being, after multiple assessments from people that never met Simone, was that she would not be safe in the community and she needed to stay on site where she was and transfer into adult services. So every move I made, I was fought back. There were a lot of meetings. It was incredibly stressful. We had what they call a prohibited budget. So that's a budget that they had put together, which didn't incorporate my care team and what they needed paying. What it was is that they created a budget that was agency nursing 24 hours, 7 days a week. So it was called a prohibited budget. So they thought that would stop, that would be the end of it. That would, you know, put paid to all of this. So I found a lawyer, which I've mentioned, and things began to change. We lost the house, needless to say, the house was lost. And so I found the lawyer, and so he told the CCG that they would have to replace the house that they lost. That was the first thing that happened. And he said they had to replace the house they'd lost because of their negligence. Court proceedings were initiated. An independent nursing assessment came along a little bit later on, and this nurse did meet Simone and spent plenty of time with her and with me. And her findings were that Simone could be safely cared for in the community by mum, and that she should be transitioned as soon as possible out of children's services. And when we read this assessment from the independent nurse, to say it was a victory was an understatement. So at this point, the current provider, for reasons unknown, decided to remove Simone from the waiting list, and they withdrew her offer of placement. I couldn't believe it. It was a shock. So their reason and their reasoning for that was that they stated that mum never requested she was on the waiting list. Well, that's absolutely categorically a lie. So Simone was actually basically stuck in limbo. We'd lost the house. We had nowhere to go. I was in a 2 up, 2 down. She couldn't come home with me at that point. And we were stuck. Ofsted got onto this quite quickly and were alerted. The CCG employed a barrister. The local authority had their lawyer, and Simone had her own lawyer, because they had to appoint a lawyer from the Court of Protection. 2 providers were involved, the one that she was at and the one that I had identified 2.5 hours drive away from me was a full-time residential college, was the only place, it was the only choice I had. As it happens, the college that she did go to was outstanding. So that soothed me and reassured me. So she did move to her new college eventually. It was incredibly difficult. There was a lot of animosity. And so Simone eventually transitioned to her new placement in September 2018. She was 19. She was 19 and it was a bumpy landing. It was a very bumpy landing. The previous provider was very unhelpful in ensuring her safety. And they sent up one person to hand over. There was a lot of pressure on me. There was a lot of pressure on the staff on arrival. There were some problems with the new provider in terms of actually their transition plan wasn't correctly implemented on hindsight. What happened was we had nurses who lacked skills and confidence to look after Simone safely, particularly in terms of suctioning and use of O2. Some of the care staff, and I have to admit, one of them actually said to me, I quote, "I'm too afraid to be left alone with her." I quite admired her for that. And as a result, between January 2019, things began to happen with Simone's health because they weren't skilled enough to look after her. And we had 7 unprecedented hospital admissions, all to resus. And that was between January 2019 and June. So that's in 6 months, 7 hospital admissions. and how she kept bouncing back, I'll never know. But what happened was eventually it calmed down with the new provider because of the absolute dedication of the team to get things right, and an amazing registered manager who I worked very closely with. And she started to enjoy her college life, but it took a lot to get her settled. And also she had probably what I can only describe as the best care core team I've ever seen.
Well, thank you very much, Sue. A very powerful story. A very powerful story highlighting exactly what we all knew, a long time ago, is that you've got to plan for transition. It's good that you eventually, did find a safe landing place. And hopefully your final memories are better than they would have been, 6 months earlier. So thank you very much for setting the scene for us. We'll come back to questions in the thing. Thank you so much, Sue, for sharing what happened with Sue.
You're welcome.
Okay, thank you very much. Right, can we now go on to our program, which is, as I say, been very generously funded. Lizzie Chambers, who's Director of Programs, and Julia, who is the Projects Manager at Together for Short Lives, they masterminded this whole project. It was very complex, but I think, as you will see, it was well worthwhile. So, Lizzie or Julia, which is going to start?
It's me starting first, and I'm going to give an overview of the 10 projects that were supported by this fund, and just wanted to echo comments from the chat to say thank you to Sue. I've had the privilege of knowing Sue for several years now. She's been a real champion for Together for Short Lives over the years, and it's really hard to listen to her story, but I know that at certain times she's come to us and felt supported by our guidance and things. So thanks, Sue, for sharing. So the Improving Transition for Young People programme were delighted to receive the funding to support the 10 projects. Sorry, I'm just there. And you can see from this slide that 2 of the projects started in October 2017, with the remaining 8 following on or just after November 2018. Across the 10 projects, there's a real mix of those teams leading the project. So 4 were led by children's or adult hospices, 3 were led by national charities, 2 by NHS hospital teams, and 1 by a professional body. As we wrote our original risk assessment back in 2016, one thing we didn't include was a pandemic affecting the whole nation. And you can see the dotted line in March 2019, when the world went into lockdown. And you can imagine how that impacted on several of the projects, and you'll read in their evaluation reports how they adapted and changed, or the impact that the pandemic had on their delivery. So in the next, hopefully 10 minutes or so, I'm going to give you a flavour of 8 of the projects. I'm delighted that Helen and Kath and Joe are here to talk about 2 of the projects directly a bit later on in the programme. And if you want any more information about any of the projects we talk about, then you'll find them on our website, and we're going to circulate these slides after the presentation. So the first project was led by Martin House Children's Hospice and colleagues from St Leonard's Adult Hospice, and they worked with a group of young adults, putting them in the driving seat to determine ways they could enjoy time together and expand their worlds. The 2 pictures you can see on the left are promotions for events that they were held when they shared the film they created, and photographic exhibitions on challenging perceptions. The project evaluation highlights some of the key learning from the activity and identifies some of the project outcomes, as we can see on the right of the screen. So an increased sense of agency, lots of new confidence from the young adults, new learning, and increased awareness through the BBC and promotion of the events they put on, but across NHS England and public events, there's just a new awareness of this group of young people and their ambitions to reach out a little bit more. Some of the key points, key learning is the passivity that they saw amongst the young people originally. You know, they really hadn't been asked what they want to do and how can we help you do what you want to do much before. And it was, their confidence was low, so that the sense of having a peer group around was really important for them. But of course, one of the strong points that they've emphasised here is that it takes so much time to get these groups, these young people forward, to move forward. So it took a lot longer than anticipated to get the project off the ground. We're delighted that as the project funding ended, the group elected to continue to meet. And when they were asked if they wanted support to manage their budgets and accounts and things, they said, no, we're going to set up our own bank account. We want to do it ourselves, which shows real testament to the growth in confidence experienced by the young people. Volunteering Matters was led a project called Futures West Midlands, where they match volunteers with young people to support access to work-based opportunities. Through the project, 12 young people who had been supported by Acorns became involved, and they were offered work experience, work preparation mentoring, and engagement on one-to-one workshops. Of course, alongside the activity with the young people, the volunteers that work with Volunteering Matters will also offer some training to volunteers. It was quite an eye-opener really for Volunteering Matters to realise how difficult it was to introduce these young people to workplaces and opportunities. There was initially quite a low take-up on offer for young people. It was quite daunting. It took time to build trust with the young people and their parents too. And young people hadn't really thought much about what sort of workplaces they would want to go to. So they had to work quite long and hard with those young people. In parallel to working with the young people, they worked with potential placements. And of course, they realized that whereas many might have met basic access requirements, they weren't able to cater for these young people with complex needs. There was insurance issues, access issues, and of course, many of the young people needed one or two carers with them at all time. But all this learning is captured in the evaluation, and those young people who benefited from the project did have increased confidence. One went on to further education, and they developed skills in CV writing and things. There's also real impact on the volunteers themselves, and those places that had thought they were disability accessible realised that they needed to do a lot more work. So the evaluation report has recommendations of how to overcome such barriers and maximise opportunities for these young people. The Royal College of General Practitioners developed this slide, and I apologise for the size of the writing. I'll talk to it because it's I don't know about you, but I have to squint to read this. But this project was centred around the multidisciplinary palliative care teams, which are usually already present in most general practices around the UK. The team undertook a literature review and then worked through a steering group and pilot sites to identify and test recommended approaches to improve transitions within primary care. The learning gathered from these pilots then fed into an e-learning course that's available to all primary care practitioners across the UK. The e-learning course is available free of charge to all on the RCGP's e-learning portal. And since its launch last summer, it's had one of the highest open completion rates of all courses available to GPs. Talking about sex and relationships, Young People Speak Out was led by the Sexuality Alliance, with young adult members of the adversity team. The project co-created resources to support young people, carers and professionals with talking about sex and relationships. They learned that co-leadership and co-creation of the resources with young people helped to secure the authenticity and the reach of the project. And they learned that co-creation requires deep commitment and considerable resources to be effective. The resources are free to use and adapt, and you can see here they're award-winning. They've been downloaded by thousands of users. The young people who were part of the project developed confidence skills and long-lasting friendships, and the project team continues to provide training to support to individuals and organisations. So the resources developed through the funding are continuing to be shared across the country. You can find out more about the resources and about the project on those links there. Moving on to the next slide. So Royal Devon and Exeter NHS Foundation Trust had already started piloting an approach to inviting young people and their families to clinics, multidisciplinary clinics. Unfortunately, they hadn't had time to capture the learning from these clinics. So despite all the rave reviews from parents and professionals involved in that, there was a risk that they'd have to stop. But the Improving Transitions for Young People funding allowed them to continue this activity for a further 24 months, during which they held clinics at specialist schools and community hospitals and invited a multidisciplinary team to work around the family and the child. The teams involved health, education, and social care, and within health there was the adult physician, paediatrician, and GP. In parallel to running the clinics, and they managed to run 3-hour clinics up to 20 each per year, moving online during the pandemic, they were busy collecting the data for a business case. And we were delighted that as they approached the end of the project, they submitted the business case to the Health Trust and secured funding, ongoing funding. So this clinic's now continuing down in the Exeter area. Up in Sunderland, Dr. Karen Horridge worked with partners to capture and evaluate the successful model for developing the right transition care pathway for every young person. If you're not familiar, this is a QR code. So by holding your camera or QR code reader to it, you'll have access to the toolkit. The project funding enabled the team to pull together all of their practice into one toolkit for others to use. And the toolkit lists recommendations for anyone working in transition to follow and introduces a range of tools, information, and resources to help professionals come together alongside families to ensure that their care being provided meets the needs and wishes of the young person. Acknowledging that a one-size-fits-all approach to transition does not work, their model addresses the need across the whole spectrum of disabilities to ensure that transition care pathways are truly designed around need. Sue mentioned that she has since become involved in the Expert Parent Programme, and the Council for Disabled Children team used their funding to develop a new Expert Parent Programme specifically for parents and carers of young people with complex health needs facing the move to adult services. This module builds upon their previous disability workshop and those they've developed with the RNIB. Content for the workshop was co-produced with parents, piloted, and then delivered to others by parent trainers. And to ensure its longevity, a Train the Trainer workshop was also funded. So there's now a bank of parent trainers ready to deliver the course across the country. During lockdown, they were agile enough to reshape the one-day workshop to be delivered over 2 online shorter sessions, and they continue to deliver the course in this blended way. The 8th project was led by T. Haffen, and they rolled out a program of one-stop shop hubs at adult hospices with a range of paediatric and adult staff. They held, sorry, I'm clicking at the same time. The 2-year programme had quarterly events in each of the 3 settings across South Wales. They learnt through the project that the fun and the social atmosphere, having the families and young people to attend, was as important as the support available once they got there. And the importance of a key worker and contact and facilitator couldn't be stressed enough. A further key learning was the importance of developing a good relationship with a consultant in that area. The impact and legacy continues. There's been nothing but positive feedback from the young people, families and staff involved in the transition hubs. A clear need for the continued transition nurse or key worker was highlighted. And again, we're delighted that they've now got a funded transition nurse post to continue this work across other areas in South Wales. And through the activity, they managed to streamline the processes and paperwork across several health boards, and this continues to be the case. And at this point, I'll hand over to back over to Lizzie. You'll hear about St Oswald's and St Elizabeth Hospice later. Thank you.
Okay, thank you very much, Julia. I mean, there's a lot of information there, but I think the important thing is that all of these projects are very willing to share their learning, with people. There's an awful lot more in the reports that we've got. So I would urge you to take these, slides that Julia has produced as a taster of what you should be looking for. There's all sorts of things that you can find in here, to help your families. So, Lizzie, over to you.
Hi, I'm just going to wait for Julia to stop her screen sharing, and I'll share mine.
Sorry, I'm showing that. Sorry about that.
Don't worry, these things happen. Okay, so I'm going to talk to you a little bit about the national evaluation that we did of the transition programme. So as a programme of innovation, it was testing out sort of new ways of supporting this population of young people. Capturing the learning from these projects was really important to us. And I think that was learning about what didn't work as well as what did work. So we're going to be launching this evaluation report today. I think we're going to hopefully share the link with you in the chat, and we'll send it out afterwards as well. But I'm going to just talk through some of the key findings that we found from the programme. So this is our approach that we took to the evaluation. Basically, we carried out 2 interviews with the project leads, so one at the midpoint and one at the end point of their projects. We asked them about what had hindered and what had helped them in their projects, as well as what they sort of might do differently and their key learning. We also, during the programme, we held what we called sharing and learning events with the project leads. So we held 6 of those over the course of the programme. And they were kind of really helpful in coming together and just sharing challenges and successes as well. So we captured some of that learning too. An important part of our evaluation was that we commissioned York Health Economics Consortium to carry out a kind of review of the economic case for adopting these transition approaches, and some really interesting findings coming out of that, which Jo Hannon's going to share with us later. And as Julia and Alan have said, each project also carried out their own evaluation. And those are really worth reading because they captured the real sort of tangible and practical learning about their projects, as well as feedback from young people and parents and their staff teams. And I just wanted to say a quick thank you to Dr. Antonia Beringer from the University of the West of England, who sort of helped in putting together this evaluation report. So this is the interview matrix that we used when we talked to the project leads. So it was a rough guide really to the interviews that we carried out. So we were asking them about when they started with the project, what they were hoping to gain from it, what their expectations were in terms of aims and objectives. We asked them about how the projects were going, what helped and hindered, if there was something you'd change, if you started again, what would you change? And also we asked them about sustainability. So what would help the project continue or spread to other regions? And then finally, we just asked them, what would you say to someone else starting out? So it's quite quite broad questions, which was interesting. And then we analysed the interviews that we undertook, and we grouped the findings into three main areas. So the first one was relating to the young people and parents themselves. The second one was around organisational issues. And then the final one was around the external environment, so the kind of system out there and the public. And we also captured some learning about COVID, which, as Julia said, kind of, impacted the projects really in a big way. So we captured some of that learning as well. So starting off with young people and parents themselves, I think one of the key findings on this was just the low numbers of young people out there. It makes it really difficult to prove the need to adapt services for them in a resource effective way. Because the numbers are very small in a catchment area, it does mean that often you have to sort of reach beyond your boundaries to bring together enough young people for things like social events, which can be quite tricky in terms of funding. And I think we found also the low numbers are particularly an issue for GPs. The Royal College of GPs project did find that quite a challenge. I think for the population of young people that we're talking about, they have such a wide range of needs. Some of these young people are relatively stable, relatively independent. Others have profound multiple learning disability or a rapidly kind of deteriorating health need. So it's, these changes over time in terms of their health that makes their transition really much more complex than for disabled young people. And it really means that you need to take a tailored approach, which takes time, basically. One other issue was around just the fact that these young people are often very disempowered. They've often been quite cushioned in children's services. So they don't have a sense of self-agency. They're quite passive in their approach. So it was quite more difficult than projects expected, I think, to encourage young people to have more engagement and more self-agency in what they were doing. And there was one point raised just about, the fact that these young people do have unstable conditions. It means that there are risks attached when you're providing services or holding events for them. They don't always, share the risks with you. So it's just being prepared for that. So some of the facilitators of working with this week were probably not unexpected. It was about engaging early with young people to build their confidence and help them find their voice. It took a long time to empower these young people to take on a more active role. And it's, I think important that you work kind of at a level that the young people are comfortable with, and it's finding out what that level is, which takes time. Co-production featured very strongly in the projects, particularly with the Sexuality Alliance project. And, they talk in their evaluation about the kind of shift in power, where the voice of the young people had actually grown louder than the people running the project, which was a challenge to manage. But, the team there felt that the co-production approach gave real integrity and richness to their project. And finally, they're really importantly, the importance of engaging parents. Often it is the parents themselves who are organising and planning the transition. They're often the key to young people finding out about services and being able to access them, and providing a safe space and a trusted point of contact for parents was critical. So this is just a summary slide of those factors. So moving on to organisational challenges. So there's a few things that I've picked out here. One was around just lack of physical space and facilities. It did hinder delivery for some of the projects. It made things like providing short breaks quite difficult for young people. You know, doing outings and activities was difficult in finding sufficient space. But also in hospital and clinic settings, just finding the space to bring people together in busy units was difficult. And obviously, as Julia mentioned, in terms of work placements, it was really difficult for employers to provide that amount of space. Staff turnover was mentioned, so just needing to have continuity of staff and contingency planning for that if it's not going to be possible. Yeah, two of the NHS projects mentioned just the NHS bureaucracy, probably again not a surprise, but just, you know, the layers of bureaucracy that slowed down their progress with things like getting ethics approval, being able to achieve staff time for the project when roles are quite rigid. So that was a key barrier for them. Another one was just around the social needs of young people. So projects that were more kind of health related, they did struggle a bit to engage young people in them. Health isn't top of the list for young people. It's, you know, the social stuff is more important to them. So think about that. A key one in our sector, in the palliative care sector, is the differences in the child and adult hospice model. So just looking at you know, how to overcome those differences and the perception that adult hospice is about end of life, and that, you know, it can be different. So that was a real challenge, and I think it's great that we've got a couple of projects here who have shown that it can be done, which is great. And then finally, there just organisational gatekeeping. So this was really where projects were trying to promote what they were doing to young people and to parents, and issues with, yeah, partners just not really being familiar with what palliative care is, and talking about end of life, that kind of thing. So it was organisational gatekeeping was quite a problem for some of them. But the facilitators, I think I've put at the top there having transition champions and having an identified transition coordinator role. So I think two of the projects used the funding to employ a transition coordinator, and that was really quite critical, as well as just finding kind of movers and shakers in children's and adult services to make it happen, and share the responsibility of transition. A really important one was around supporting staff in adult services, so providing training to build their confidence. Often they're just not familiar with the kinds of conditions that these young people have. So providing opportunities for training was key. I've talked about a safe space for parents, but that was really important, where they can, you know, share their experience with other parents who've got young people with such serious health conditions. But that safe space could be face-to-face, but it also was shown to work virtually as well. On a really practical issue, transport was mentioned, enabling young people to get to services was really key, and also having a clear identity and brand for the service. So I think one project we're going to hear about later really found that helped, having a brand that people could be proud of and take ownership of. So that's just a quick summary of the organisational factors. And in terms of the environmental challenges, I think those of us who work in palliative care will be very familiar with just the fear of and misconceptions of what palliative care is. It's still seen very much as about end of life care, and just, yeah, much more needs to be done to try and dispel those myths. Another challenge here was really just having a lack of information about this population of young people, where they are, what the services are out there to support them. And it takes lots of time to gather all that together and prove the need. But once you've got it, you know, projects really flew basically when they had that evidence gathered together. Continuing care was mentioned in particular, the adult statutory sector, bodies and continuing care in particular. And also just the length of time that it takes to build partnerships and to maintain those partnerships as well. Quite a couple mentioned strategic engagement really dropping off partway through the project. So it's having those champions to keep that going. I think particularly projects around GPs very hard to engage with. I think we've known that was one of the key things we wanted to try and test out with this programme, was, you know, how you could really successfully engage GPs in supporting these young people. And one project mentioned the importance of trying to sell their involvement in transition as essential core business, not just nice to do. But yeah, there's a lack of capacity basically in primary care. In terms of facilitators, a key thing was around building on what is there. So don't invent the wheel. Try to sort of empower staff in existing organisations to be able to support these young people, not taking over. And the other thing was just being really flexible. I think there was recognition that transition for this group of young people is still quite experimental. And so just, you know, needing to try and try new things, adapt as you go along, take feedback from young people and parents, be quite organic. So that's just a summary slide of those environmental factors. And then finally, I just wanted to share some of the other key learning that projects mentioned. In terms of young people themselves, they talked about just the impact of their complex health needs on their daily lives. It was huge, and the need for a really person-centered approach to understand what the impact of those conditions are and what needs to be adapted for these young people. As I've mentioned, co-production was mentioned quite a lot in the question about key learning, and the importance of developing relationships with young people. In terms of organisational factors, again, training came up, probably the most commonly cited thing. Cross-organisational engagement, so from the very top of an organisation down to grassroots as well. Providing peer support for young people, so making sure that they support each other to engage in activities and allowing sort of platforms for that to happen. And yeah, the other key thing I think was having a dedicated transition coordinator role. So that was really key to the success of a couple of the projects. And I think just, you know, allowing time to build partnerships and allowing time to really just try and raise awareness of what palliative and hospice care can provide as well, the kind of positives that are there in terms of therapies and social activities, that kind of thing. So just a slide here just on impact of COVID. So it did scupper some of the projects slightly, both in the delivery of what they were doing, but also in their evaluations. So projects, particularly that were aiming to work with clinicians and in particular GPs, they were really impacted because staff were redeployed. Many of the projects, their kind of direct service delivery had to cease, and they had to adapt to virtual working. And they did find some benefits to that, but I think mainly they were just aware that it didn't suit all young people. And yeah, for some it was a real barrier to engaging, because you just can't build the kinds of relationships that you need in building trust. But on the flip side, I think one positive impact was that families were more open to being contacted. It kind of in some ways opened doors for them, which was really beneficial. I thought I'd just include a slide on what's next for us. So we really want to make sure that we capture all this learning and help it to spread to other areas. So we're going to be using a lot of the evidence from this programme in the update of our transition pathway, Stepping Up, which is coming later in the year. We want to do some work around supporting better commissioning of transition and capturing data on what the gaps are, so we know what we need to fill. We want to grow our professional forum for sharing, learning and networking, so in particular engaging transition roles in that. We're looking at developing an education and training programme and kind of influencing training that's available on transition. We want to support the rollout of the expert parent programme. That's really important. And also develop some kind of peer support platform for young people as well. So a lot of exciting things coming up. And I just wanted to conclude with obviously I want to thank Professor Sir Alan Craft, who chaired our panel, David Strudley, who, as Alan said earlier, led our transition task force for 4 whole years, David Lerner from one of our funders who really was there from the very beginning of the programme, Dr. Antonia Beringer, who helped me with the evaluation, all members of our shortlisting and interview panels, there are quite a few of you, you know who you are, to all of the project leads and team members, and the young people and parents who contributed to the programme as well. And just a final thank you again to our really amazing funding organisations for their vision in supporting this programme. So thank you. I think I'm just about on time, Alan.
No, that's, I've started the video, right. You stop the video.
Yeah, sorry.
Right, I think you need to stop share. There we are, right. Thank you very much. Right, thank you. That gives you an overview of the various projects. And as I said, when Julia had finished, there's, we can do no more today other than just tell you a little bit about the highlights and what is available. You really need to go and look at these projects and see how you can adapt them to your particular situation. I mean, one of the points that Lizzie has just made there is one of the challenges that we have is that children and families with these sort of needs are unusual. And you can't, it's actually, you can't get a lot of people together and provide a great big service. It's got to be individualized. But at a regional level, which is what the task force worked at, you can try and ensure that, across your patch, your region, that you do have appropriate services available. So we got to the stage where it says comfort break. So you may now disappear. The time is, let's say it's 11 o'clock. Can we come back at 10 past 11 when we will hear what is a very important paper on the economic case for transition. If you can actually show to your funders that it's worth doing economically, then that gets you a long way into the system. So off you go, have a coffee break, do whatever you want to, but please be back by 10 past 11. Thank you.
Thank you.
Okay, I hope everyone has returned. The time is 10 past 11, and we're going to move on to Joe Hanlon, who is a senior research consultant at the Youth Health Economics Consortium. And this is a very important, well, all of the papers are very important, but this is something slightly different, but it's going to give you the ammunition which you all need to be able to get the resources that you all need and the young people and their families. So Joe, give us the answer. Is it worthwhile?
Thank you very much, Sir Alan, and hello everybody. So I am going to share my screen in a moment with a few slides, just to tell you what we've been doing over the last couple of years to try and gather some evidence of the economic impact to answer that very question. I think it's probably fair to say that it's quite a challenging question to answer, in the same way that some of the challenges of evaluating this kind of service have already been highlighted. I will share my screen now. Can I just double check you can see my slides rather than the preview slides?
It's fine, Joe.
Thank you.
Okay.
Yeah, thank you.
Okay, so as Sir Alan said, I'm a senior research consultant at York Health Economics Consortium at the University of York, and we've been working with Together for Short Lives for the last 2.5 years on this piece of work. And I'm just going to give you an overview now of what we did, so what the aim of that work was, how we went about it, some very sort of headline findings in terms of the features of the projects, what that meant from a resource input perspective, and some of the economic outcomes that we were looking at. And then some cost analysis and some brief thoughts on the project specific findings. What I'm not going to go into lots of detail on the individual projects here, but more in terms of in general terms, and some overall calculations that we did. However, the report and individual case studies go into more detail. I'll also say a little bit about the challenges that we came across and some headline conclusions. So the aim of the evaluation from an economic perspective was to pragmatically evaluate the costs and benefits of each of 4 of the 10 projects that we focused on, to try and determine the cost effectiveness or the cost consequences of the projects. And that was from the perspective of providers and commissioners of NHS and social care. So we understand that the funding flows may well be coming from commissioners, wherever they may be in the system, as that changes around us. But it's also very important to get the perspective of providers, and I think that's even more the case as we're moving towards the world of integrated care systems. What we were trying to do is to identify, measure and value what we call the incremental costs and benefits. So the incremental meaning the difference. So what's the difference in the cost that are incurred with the service as opposed to without it, and equally what's the difference in the benefits, what are those net benefits. And so we've developed case studies, but brief case studies for each project, and they're contained as a chapter within a final project report for TFSL. So we're still putting some finishing touches to those. Apologies, that's not ready to share with you today, but it will be within the next few weeks on the TFSL website, and the individual projects will be able to have their own chapter as a standalone case study as well. So what did we do? So we worked with 4 of the projects. These are the 4 that we worked with. So with St Elizabeth's Hospice, St Oswald's Hospice, so with Helen and Joe, with Chloe and Jasmine at Royal Devon and Exeter, and with Tracy at THFAM. And we liaised with the projects. So at the beginning, it was about us trying to understand the intervention and what's usual care. So what might we expect to happen in the absence of the intervention? How might that intervention lead to the proposed outcomes, and which of those are what we might term to be economic outcomes? What's the cost of delivering that service? What are those incremental costs? And we discussed with each area what the plans were for data collection. We were keen to use existing data collection methods where possible, because we're more than aware of the difficulties of introducing additional data collection burden. But there were some methods discussed and proposed by the projects, partly as part of the planned the other evaluation that was being undertaken by each project, to join in with that and collect some economic information. So to include some questions in, for example, into surveys for professionals and other research and evaluation that was going on. And we developed costs for each project based on the analysis frameworks and that early thinking, also using the project budgets that were set out in the applications, and then subsequently on looking at the actual expenditure, and then also using the evaluation reports that were undertaken by other evaluators. And we developed those costs to reflect the actual resource required, rather than the projected or planned expenditure at the application stage. So in terms of features of the 4 projects, I will skip over these because I think they've been well covered in the previous presentation. But I think in terms of the key components, that the resources, the additional resources were helping to fund, these were what we could see in our work. So really importantly, the multidisciplinary approach and the opportunity to provide a one-stop shop type approach with a number of different health and social care professionals and other disciplines being available to young people and their families. Excuse me. Very importantly, a proactive approach with care planning, and the care planning element has come through, I think, as a key feature that can assist with the ability of families and the healthcare team around them to determine what happens particularly at the end of life, but when crises occur, and that can potentially have an impact on mitigating against expensive admissions to hospital. So that came through as a theme as well. The coordination of care and having an overview of the whole range of important factors around care for young people and their families, forums for young people to come together, either in person or virtually. And although some of those measures did become virtual because of the pandemic, what's come through from some of the evaluations to me is that those in some cases have been very successful ways of young people interacting. Tools and guidance and training for staff, so support for particularly for non-specialist staff or people who don't work with this group regularly to increase their confidence and again potentially reduce their likelihood of calling upon other health services because they've got more confidence to deal with certain situations themselves. Services being more tailored to young adults and their needs, and then building familiarity with hospices and the hospice team. So those are key features that seem to come through. And in support of resourcing those key features, these are the kind of additional or incremental inputs that we found. So a coordinator, whether that be a nurse or not, a role to do quite a lot of coordination, supported by an administration worker or support worker of some kind. And those seems that I think in the 4 projects we worked with, that was a feature through most of them in terms of the staffing that we've costed in there. Then other elements, clinicians' time and other professionals, in large part included in their core roles, but just delivered in a different way. So in general, those have not been costed in as additional time, but 1 or 2 have. Venues and activities for workshops, meetings, hubs to take place. Project management resource, largely supplied by senior clinical management people who are in those roles already, so not employing a project manager per se, but giving up some of their time to oversee the project, which potentially they wouldn't have had to if the project hadn't been running. So so we've acknowledged that here. And then other resources such as sort of hardware like telephones and laptops. And in order to try and assess how much all of that costs, what we've done is calculated an annual cost based on the reported inputs in the first year. And I do mention this later. So this is, we would always err on the side of being conservative in economic evaluation. So we acknowledge that some of the costs that are incurred in the first year may not be incurred in subsequent years as services become embedded or hardware has already been purchased and so on. So that's in the interest of being conservative. So we looked at that first year cost. We've also costed these at 2021 prices, because although these services started prior to that, what we think is probably more useful going forward is what would this cost? If somebody's reading these reports thinking, well, what kind of resources are we, what's the implications of this now going forward? And that doesn't make a huge difference actually, but what it does mean is for certain things where we've taken prices from previous years, we've inflated them to the 2021 prices. And I've used recognised sources of unit costs for different items here. So the unit cost of health and social care, which is produced by the Personal and Social Services Research Unit at the University of Kent, is a recognised source that we tend to use in health economics. And what this does is, excuse me, it takes into account all of the resources required to deliver a unit of something, whether that be an Agenda for Change by Nurse 5 or a night in respite care. So some of the costs you will see, you may not recognise them as the cost to your particular organisation, because what PSSRU does is look at what is the cost to the system. And that's how we've done the costing. Again, that's the usual way of doing things in health economics. We've also used other sources like the NHS cost collection. So what we're looking at is trying to represent the opportunity cost to the local health economy. What are the economic outcomes that were of interest? I've separated these into three categories. So I think from the perspective of the health and social care system and resources, it is of certainly of interest to look at utilisation, or I should say use really, of services, whether that be the number of contacts with healthcare professionals such as consultants, whether it be paediatricians or palliative care or other hospital-based services, or appointments with GPs, attendances at A&E for situations that need immediate attention, admissions to hospital, in particular unplanned, where care is needed, where people, young people are deteriorating and their care is potentially not being as proactive as it might be. And I think this was one of the key features that I think that came through all of the projects, is the ability to improve the quality of care and mitigate against unplanned crises, and the recognition that an admission to hospital for this group could well need a high level of care. The potential to reduce hospital stays, because while notwithstanding what I just said about hospital admissions, we also recognise that they are also sometimes very necessary and very appropriate. So no one's suggesting that these services could prevent all hospital admissions, and it wouldn't be realistic of me to say so. And then finally, treatment for anxiety and depression. This came through in one of the case studies, but we recognise the ability to have a positive impact on the health and well-being of families. And that's reflected below. So the health and well-being, improved health and well-being for children and young people and their families, hopefully fewer crises. In some cases, potentially the ability of parents to go to work, so potentially seize claiming benefits and increase earnings and productivity. And then finally, service efficiencies. So this was a feature, saving contact time by using a multidisciplinary approach or group settings for providing services, and potentially avoiding other appointments because service needs are met in other ways. So the average cost, so I should just note a caution to the projects who are on the call, you may not recognise these exact costs for the services, because as I said, we've costed them from a using the unit cost of health and social care, based on the information available about the resources that went into the project in the first year. And we've come up with an average across the 4 projects of an annual cost of just under £47,000, which I'll let you sort of form your own judgment about whether you think that's very much. I think in the grand scheme of things, that's not very much, really. The value of resources that we use, I've included this just to give an idea, an indication of when we're talking about health and social care use, of what some of those unit costs look like. I'm not going to go through these in detail in the interest of time. It's probably not that interesting for you, but you can see the sorts of sources that we're using, and the sorts of values associated with those. And as you'll see, the admission to hospital there for this particular group, using the PSSRU sources uprated from the previous year's version, is considerable, so just under £9,000 on average. So what we've then done is a threshold analysis. Now this is, I've done this at each of the projects, but just based on that average first year cost, how many of these would you need to avoid to effectively be cost neutral with your project? And if you think back to these different costs, there's considerable range here, and as expected, that's reflected in the number of different healthcare resource use that you would need to avoid to effectively be cost neutral to that health economy. And the admission to hospital, you wouldn't need to avoid very many at that unit cost to be cost neutral. If you look at GP appointments, on the other hand, they are relatively low cost because they're a short in contact time, and that you would need to avoid a lot of those across your cohort to be cost neutral. But I think anyone suggesting that any one of these things would be the only outcome, and that we're looking at a combination of these to be avoided across the year. So moving on, conscious of time. So key points then on resources across all the projects. Firstly, that improved coordination of care and improved wellbeing for young people and their families was achieved. So the improved wellbeing being reduction in stress of caring roles, for example, preparation for bereavement, improved multidisciplinary working, awareness amongst families of the services available, and the increased likelihood of using the hospices instead of the hospital, which was a feature that came through. But I think it's also important to acknowledge that the roles, particularly the transition coordinator roles, might identify unmet need, and if services were previously not being used or needs not previously being met, this might lead to an increase in use of services overall. So this isn't just about saying, well, can we save lots of resource use and the associated cost of those. So for St Elizabeth's, then there was certainly some evidence to suggest that the transition coordinator role resulted in reduced tasks for other roles, and some reduction in duplication of effort across organisations. And what we've done with that, there were various sources of people's opinions about how much they felt that role contributed to that. And then the qualitative evaluation also, we got some feedback from that supported the potential to reduce healthcare use as a result of improved coordination of care and improved transition. For St Oswald's, this I think was tricky to draw big conclusions from, because the numbers are quite small on that, but with the evaluation was useful for us to have a look at. Certainly there's very positive feedback on the value of the MDT and the joint working, and we've done a threshold analysis on that one, which is looking at the service model as described in the TFSL funded project, but also the consultant only model, which I understand has continued. And then for Royal Devon and Exeter, they did some really good work looking at a comparator group, and they found no statistically significant difference in the use of healthcare resources, which we have reported on. But what they did found was that staff reported using about the same amount of time with young people in this service model, but were providing better care within that time available. So there were gains there, but not in terms of reduced healthcare results, but that was thought to be because of a relatively small sample. And I think that is one of the challenges of doing this kind of analysis, is having a large enough sample to get some statistically significant results. And then for THAF, found some really good case studies here which showed evidence of reduced use of health services and improved care, and the transition nurse role supporting hospital admissions on adult wards, which was highly valued and helps with those admissions and potentially shortening those admissions. There were certainly some challenges on the evaluation. From a data collection point of view, some methods were always going to be challenging even before COVID, particularly the quantitative methods. Just asking busy clinicians to fill in questionnaires at the beginning of a project and then at the end so in some cases was always going to be ambitious, but some of the methods were, I'm sure we'll appreciate why they were just not able to be deployed as planned at the beginning. And the pandemic affected the ability of projects to undertake those evaluation activities. So, and another challenge is that comparator, so knowing what would have occurred in the absence of the service. So, as I said, one project which is Royal Devon and Exeter had a comparator group, but matching the patients was quite challenging on that. But we've got some evidence from clinician views on what might have occurred in the absence of the transition service, and sometimes that qualitative information is actually more useful. And then patient reported outcome measures. So while those were some of the tools that we use, we thought may be able to capture some sort of health status at the beginning and at the end. They were less useful from an evaluation perspective, although they were useful for giving sort of a baseline indication of patient need. And then capturing quantitative changes in resource use for the mental well-being of families, that really wasn't something we thought we would be able to capture. So the conclusions, and this is my last slide. So what we've done is a cost consequence analysis, so describing the costs of the services, describing what the consequences are, and describing what those outcomes and consequences are. There's some examples of reduced use of health services by young people and their families, and while they might not be cash releasing at the immediate point of use, they could assist with service pressures in the system. And then on top of that, there's this threshold analysis, which it gives us the ability to judge the likelihood of an intervention being cost neutral, while at the same time improving the quality of care overall. And the interventions are relatively low cost when compared to high value healthcare, which they might prevent, such as a hospital admission. We also acknowledge the cost in subsequent years might be lower than the value shown in the report as services become embedded. And the awareness of the adult hospice and the likelihood of making use of those services rather than an alternative to hospital was something that we thought was a realistic finding. It was a challenging evaluation environment, complicated by COVID-19, and I think as a result, the qualitative evaluation was more successful in identifying the outcomes. So we made best use of that as we can. So that's the headline finding. Sorry if I've gone on a little bit over my slot, Lizzie, but I shall stop there.
Okay, thank you very much. No, you haven't got, well, you've gone over marginally, but that's all right. Some very important information there. And clearly, each of the interventions that we have needs to be costed and looked at individually. And I think what you've done is to highlight the areas, it's not only about saving money, it's opportunity costs, it's about improving care. And I hope that people will be able to take away from that ways that they can evaluate their service and prove to funders that this is worth doing, even if it's only improving the quality of care and spending the same amount of money. Ideally, it should be, spending a bit more money and getting better care. But I think even going back to Sue Ben Abraham's presentation at the beginning, the somewhat shambolic events that she described ended up with her daughter being in hospital 6 times, probably unnecessarily. And that's a huge amount of money which is spent. So thank you very much for doing the economic bit for us. And there may be some questions in the question and answer session later on.
Thank you.
Okay, so can we now move on to 2 other of the projects? One at St. Elizabeth Hospice and the other one at St. Oswald's Hospice. And Helen, over to you to tell us about the impact of the service. What have you done and what did you find?
Hello there, good morning everybody. I'm Helen Finlayson from St. Elizabeth Hospice, representing the ZEST service. I've got my colleague here, Kath, with me today as well. I'm just going to share my screen and hopefully, is that showing for everybody okay?
Yes, it is.
Lovely, thank you. Okay, so reporting on the Transforming Transition Experiences in Suffolk project. So going back where we were right at the beginning when we were fortunate enough to gain this funding, we were a really small team. So I was working in the adult hospice. I'm an OT by background, managing the day services and developing a transition and young adult care service. There was just myself and a very part-time activities coordinator. We had no one in our hospice staffing who had children's nursing or learning disability complex care skills that we desperately needed to progress our service. The service consisted of a monthly social group for young adults, which included a parent peer support group and 2 open events a year to help encourage transition. And we'd kind of had a bumpy journey and we really needed to bring in some more expertise, and that's what we recognised across Suffolk. So we had a Suffolk-wide transition group that I chaired, bringing together statutory and charitable organisations, and together we looked at what we needed most, and top of that came a transition coordinator, someone to work multi-agency and across all the partner organisations. And that's what was agreed following a big stakeholder day in 2017, and that's what we put in as our joint bid together. The aims of the project was essentially, when we received the funding, thankfully, to fund the first ZEST nurse, to pilot the transition coordinator role, to support better transition preparation, and essentially to upskill our adult hospice clinical workforce for young adults complex care, and prepare the way for our ambition to deliver short breaks for young adults in our area. As we co-produce a service, families continuously told us that's what they really needed. And to progress the growth of our ZEST service, as we had a big ambition to provide this service across East Anglia in our region, so that our local children's hospice that covered the same area could have an equitable experience of transition. So the findings that we have just recently received from our external evaluation of this project for the University of Suffolk are going to be included in this short presentation, gathered from 23 semi-structured interviews that included service users, our partner organisations and other local and national stakeholders, and credit to the researchers who kindly have taken on this project for us. And one of the quotes is here that I wanted to share that is part of the feedback that we had from the evaluation, which I think highlights to me where we were at the very beginning of this journey and how much this service was needed, and that spurs us on to continue to develop the ZEST service. So at the heart of this project was co-production. We've done everything in partnership with young people and their families as much as possible. So from looking at what the need was through to recruiting the staff that we need to deliver this project, we've really tried to keep the young people at the heart of that, which has been more challenging during the pandemic because of the disruption of services, but that's a continued commitment that we have. So the university looked at data and they took a 2-year period within the service delivery from July to 19 to July 21. When we first started the project, we had 32 young adults transitioning into our service in 2018. When the time this data was gathered last year, we had 43, and we've now got 46 young adults in our service. We looked at the needs based on the classification from Together for Short Lives of paediatric palliative care conditions, and the activity data analysis really highlighted that category 4 conditions, so those young adults that have got non-progressive conditions but life-threatening aspects and very complex care needs, were definitely the highest group of young people in our cohort and the highest represented within all areas of activity within our service. And you can see that the average age within our service is 23, and we've got slightly more males than females, but the data analysis found that there wasn't a difference in how the service was used between male and females within our young adult cohort. So the transition coordinator role was a really big part of this project. So we tried to focus on the transition between 15 to 19 years old and prioritising those category 4 conditions as a priority for the funding, but also recognising that in our area as well, this group of young people had the most bumpy transition because there wasn't progressed pathways of transition for this group. So the role that we took on was to be a one point of contact for families during transition, to take a proactive approach and to aid the navigation between children's and adult services, and provide that expert resource and bring services together, and ultimately to improve the well-being of families during transition by taking that burden from the families and supporting that journey through. So Kath is just going to give us a little bit of insight about carrying out that role. And these are some of the quotes from the family. So I'll let Kath speak now about her experiences. Are you there, Kath? You're on mute if you are.
Thank you, Helen. The transition coordinator role, as Helen said, was a new role, and I was new in post in October 2018, and we really started the transition coordinator role in January of 2019. So we had sort of just over a year of that before COVID hit. The transition coordinator role involved initially engaging with the families, and as Helen said, prioritising those 15 to 19-year-olds and those without other clear transition pathways. One of the things we learned quite early on is, although we targeted that category 4 group, we were getting requests from other families that were outside of that category 4 group that were also not having as clear a transition pathway as we'd envisaged, and having lots of questions. But for the purpose of the project, we worked mostly with that category 4 group. The areas that I was asked to support with was the medical transition, both supporting access and engagement with GPs and with adult consultants, supporting care packages, mostly the continuing healthcare packages, but also some social care packages, supporting that final couple of years at school and in education, and looking at post-education provision for care and support, and more importantly for most of the young people, activity and social inclusion post-education. It was really valuable to have a medical or nursing background, because we weren't able really in any points of transition to isolate just the social impact or the medical transition. Everything was so involved at a time where we know young people's health is often at its most unstable at that transition time, when they're getting to know new consultants and medical professionals as well. I shall hand back to Helen, but we can answer any other questions later on.
Great, thank you, Kath. So the next part of the project was to upskill our adult hospice, and Kath came from having many years experience working in the children's hospice setting. So she brought with her a wealth of skills and the confidence as well. And it made a huge difference to us to be able to develop some young adult care competencies that we were able to train both our existing adult staff and a new care team as well, to help develop the services that we're able to do. And then just these are some of the collective quotes, both from the families, service users and the staff as well. So our ambition at the beginning of the project was to prepare the way for short break service that we knew was such a priority for families and a huge unmet need in our area and actually across our region altogether. But actually we were very fortunate that our trustees felt it would be a great time to invest in piloting a short break service on weekends for a couple of young adults to stay together in an unused area of our day unit that wasn't being used at weekends. So we quickly co-produced that service with families, recruited a new short break care team and worked really closely with the children's hospice to transition short breaks for those that were then due to leave the children's hospice and provide that new service to young adults who were 18 years and over and already accessing the desk service. As part of my research fellowship with the NIHR ARC in the East of England in association with Cambridge University, I carried out a separate service evaluation of this aspect of the project, which we're just going to share very briefly some of the sort of headline findings. We carried out the pilot and it had to stop slightly prematurely in March due to the pandemic, but we had overwhelming positive feedback from both the staff and the service users with a really strong case for the service to continue and to present to commissioners. And we had lots of feedback around the benefit to the young people, both in terms of giving them increased independent social opportunities and a break from being at home, and very much an emphasis that this was about a short break for young people, which in turn then enabled the parents and families to have respite as a result of the young people having an enjoyable stay with us at the hospice. So it was a nurse-led service and very independent from our medical team, and we also had some really great feedback from the staff. So majority of the staff were recruited locally. Many of them worked in children's services and had been feeling like this service was needed for a long time and offered to work with us on a bank basis, as well as some of our existing adult staff joining that. So it really was quite an eclectic mix of staff and a great skill mix. I think one of the biggest things we felt was a success was the trust that we achieved with families, because we know that is paramount to any transition service being successful, and the care that we're being able to be delivered matching that of the gold standard that families were used to at the children's hospice as well. And I think that really spurred our adult hospice team into feeling confident, because they were having that affirmation from families that they were trusted with the care of the young people. So as well as all of this, we continued with our monthly groups and working, and really the key message really is that this partnership working with other organisations, in particular the Children's Hospice, was absolutely key to success throughout the project. And we then sort of enhanced our partnership working to include within the short breaks. In the last year of short break care within the Children's Hospice, we deliver one short break together at the Children's Hospice and then one short break jointly staffed at the adult hospice as well. And that provided so much continuity and trust for families and a really transparent one team approach for all involved, and also lots of skill sharing and training opportunities for us to help our adult staff grow in confidence, and also providing ultimately that invaluable peer support both for families and young people. So very quick overview of this is what our service looks like now. It's really transformed since we were initially funded back when we were successful. So we have different layers of support. So supportive care for everybody 14 years and upward with our peer groups and family events, hospice care for those that need that transition coordination support and regular reviews of their clinical needs, specialist palliative care from the wider adult hospice team as and when needed. And our enhanced services now have been commissioned, which we're absolutely delighted about, both for short breaks and a new day service for 18 years and over. So really highlighting the impact of the project, and we've got a new short break service. We have a new Zest Day service. We know that the transition coordinator service was incredibly time intensive, and to provide that to the number of people that we need to have that equitably, and with the other service areas that we have, we offer transition advice and support service now as much as we can to all those needing it, regardless of diagnosis. And we've now got an established team, so we've gone from just 2 of us to a team of around 30 and growing. We've now expanded our service beyond East Suffolk to include West Suffolk, so the whole of the county, and we're currently in discussions with Great Yarmouth and Waveney about whether we're able to start to develop our services to reach up into that area. We've now got a sustainable funding model, which we're continuing to build on, with statutory funding through personal health budgets and direct funding from both continuing healthcare and the local authority. And we've developed some great academic partnerships to continue to evaluate our services with the University of Suffolk and beyond. And we still have an ambition to grow the service further because we can see the just invaluable impact it's having on families. And just a brief last word for those that were fortunate to meet Dom right at the very beginning when we came to our interview for the funding. Dom has done incredibly well. He was so passionate about this project. Dom has had a successful heart transplant and is no longer accessing our service, and he's now at the university in Newcastle, where he's having an absolutely brilliant time, but he continues to support us and took part in the evaluation with the University of Suffolk, and is very happy for him to share his good news of where his life's at now. So just wanted to end on that point. And just to say a huge thank you to all of the support that we've had from the funders and Together for Short Lives, that's really enabled us to get to where we are today. And of course to all the families and our partner organisations who've been essential in moving this forward. So thank you very much.
Thank you very much indeed. A very important contribution of what can be done, making a real difference to people. Can we move swiftly on, because I'm anxious that we can get Gareth Jones in before he has to leave at 12:15. So Joe Elverson from St Oswald's, from the Centre of the Universe. Joe, over to you.
Thank you. I'll just share my screen. Okay. Right, can everyone see that all right?
That's great, Joe, thanks.
Thank you. I want to start actually by saying I'm absolutely in awe of the Zest project. That was fantastic to hear of the huge success that they have had. And one of the benefits that we found of being part of the Improving Transitions project has been hearing about ways other people are doing things and learning from them. And it was almost a great opportunity when the project finished to say, right, which bits can we snatch from different projects to see if we can make what we're doing better. I want to talk about our project, and I've put the subtitle to this, Responding to Unexpected Benefits, because I have to admit that what actually happened on this project was not what I anticipated, but actually what has grown out of it, I think, is something that's more sustainable and hopefully is going to have more benefit for more young people and their families than what I initially envisaged. So I will tell you our story. So essentially, our project was called Engaging GPs Improving Outcomes. And what we were recognising is that many young people around transition and beyond transition have multiple unmet needs. And those are physical, social, as we've heard, it's far-reaching. But quite often what we were finding is that there's no obvious lead post-transition. They may have many specialists who are very focused on their own particular area, but compared to in paediatrics, where they would have a community paediatrician who has expertise within their condition to a certain level and holds an overview and pulls the strings together and ties everything up, there was no obvious specialist lead post-transition. And the obvious answer for many people would be, well, isn't that the GP? Shouldn't that be what they're doing? But there were many reasons why that was really challenging. And that was partly to do with the fact that often the GPs hadn't been involved during this young person's childhood, or had been involved in a very hands-tied kind of way, where all they were really felt able to do was make sure the repeat prescriptions came through. But actually anything complicated had to go to the experts. And so we had a very de-skilled and unconfident population of GPs, but also patients and families who didn't feel that this was a team that they knew well, that knew them well, or that would be able to represent their needs well. So there were a lot of barriers to the GP taking on that leadership role. What we set out to do in conjunction with the Newcastle Gateshead Clinical Commissioning Group was to look at whether we could add a layer of support with a bit of expertise around the medical side, and we had a social worker and a nurse on our team as well, a bit of time, which I think is chronically lacking in general practice, to actually listen to needs, to understand what needs doing, and to do some of that coordinating role. And also that expert support where we can support both the families and patients, but also feed that back to the GPs and help the families and patients to feel that their GP did have an ability to coordinate and to lead on their care, but also had a good structure of support when they needed it. And we plan to do this through creating a team within St Oswald's Hospice as and having a light touch outpatient review of the patients. And what we initially thought is that we could do a once a year review. I think that was optimistic, because actually it takes several meetings to get to know a young person with a complex condition and their family, and we very quickly axed the idea of seeing people once a year. St Oswald's Hospice itself, we are a hospice that has an adult inpatient unit and a children's short break unit. We do also offer short breaks to young adults, but the waiting list is long and the number of places are few and far between. And I think one of the reasons that we embarked on this is we were recognizing that the young people that we saw within the short break service was probably the tip of the iceberg. That there were many, many more who could benefit from some input, and also that our upper age limit for the young people's short breaks was 25, and there was this within the organisation, this concern about what happens next and how do we support them next, because our adult unit is sadly unable to offer short breaks. So that was really the context to which we said, what can we do? And we created this pilot to see where we could go with that. And we were incredibly grateful for the funding to enable us to take this forward. What actually happened, the central project, we had a very small number of referrals and incredibly few from GPs. And reflecting on that, although we publicised widely within the clinical commissioning group, where we talked to a lot of GPs who were very positive about this, but actually every individual general practice tended to have maybe one or two patients who might fit the criteria and who they were probably only seeing annually or 6 monthly at best. And so actually translating the publicising to referrals felt like it was a very slow process. And actually in the end, most of our referrals came from hospital-based clinicians who I will talk more about, but basically who ended up forming a bit of a core around some of these patients, where we all recognised that we were seeing patients with similar needs as part of this multi-specialty group, and recognising that sort of no individual specialist was able to see the whole picture, but I'll come back to that. Of the patients that we did have and their families, there were very recurring themes around unmet needs. And I think it's important to say that these unmet needs were not specific to transition. Many of them continued beyond transition into young adulthood and even beyond into 20s and 30s. And I've put there my bottom bullet point of that first list is upper age limit, because actually in remodelling the service following this, the Improving Transition Connections project, we actually removed an upper age limit. We've said this is for young adults, but we don't have a limit on that, because we're recognising that these unmet needs continue to be unmet into adult services for now, very sadly. Maybe that will change in the future. The things that did come up, advanced care planning, and as has already been mentioned, that's not just planning for end of life, but it's planning for emergencies and crises, so that not necessarily preventing hospital admissions, but making sure that the quality of that admission is as good as it can be, and particularly given the way things have been evolving with COVID, I think the importance of that has become incredibly clear, that actually someone with an advanced care plan who is unable to communicate their own needs needs to have absolute clarity that the clinicians that know them best have said, this is how you should be treating a chest infection, this is how you should be managing epilepsy, so that that follows the young person wherever they go into adult services. Particularly in our region, there are a number of different hospital trusts that people could end up in. So making sure they have some document that they can carry with them with absolute clarity to make sure that they get the treatment that they need as soon as possible, and that nobody writes them off, which I think is a huge concern among parents that I've met in particularly, but also the young people themselves, that they come into hospital and people make assumptions about their level of function, their clinical needs, based on seeing them when they're unwell, rather than knowing what their baseline is and their ability to recover. So I think that's almost been the hugest thing. And as Joe Hanlon mentioned, that actually means that in some cases, people actually end up having more medical input, more hospital input rather than less. But I think I would argue that that's appropriately so, and actually what went before was not acceptable. We had input with symptom management, and a lot of the symptom management input was actually about signposting and involving other specialists rather than throwing a new drug at somebody, and making sure again that symptoms were properly investigated, properly looked into, recognizing that in adult services there isn't a specialty of neurodisability, and sometimes finding the expert who can manage neurodisability is a bit harder. For some of our young adults, identifying when they're reaching the end of life, and that was a very sad, very difficult process, but to actually recognise and name this is what's happening now, this is the way things are progressing, was hugely supportive to the young people and to their families. Carer support, I can't say that enough. Again, this is one of these things that I probably anticipated we'd do a bit of, but actually giving parents a safe space to talk, sometimes a safe space away from their young person to offload the challenges, particularly the challenges around dealing with care packages and funding. But actually, I think that was a key thing that we managed to offer without even realizing that we needed to, and suddenly found how valuable it was. The space to listen and identifying where people weren't getting the services that they need, looking out for people and making sure that they knew where to find legal support, where to find who to speak to about funding or to appeal about funding, and also for psychological support and counselling, and sadly in one case for bereavement counselling as well. So there was a lot of listening and signposting with carers. And need for respite and clarity with care packages has come up again and again. As Kath said in the last talk, it's impossible to have a medically focused clinic without having an understanding of the educational, the social, the psychological, because everything feeds into the same thing. And so we really had to have that holistic approach. What we also found is this additional role of supporting professionals, and some of that was with training, but a lot of it was with actually doing joint consultation, sitting together and doing the advanced care planning with a respiratory physician or an anaesthetist, sitting together in a team discussion with the epilepsy team and the PEG team and the respiratory team to work out how can we move forward with a particular situation, and making sure that the young person and their family stayed central to that. And I think throughout the project, again, something I hadn't anticipated enough, because we were starting afresh with something new. The networking and communication and PR side of the project was massive. And to be honest, we did a lot, but I think still there were more groups of people, more relevant partners coming out of the woodwork, even after the project had closed. So I think that was a huge thing that we did invest in, but we probably could have invested in more. So coming back to those themes, this was a way that I tried to sort of pull it all together in my mind, thinking about the things that we did. So there was the direct clinical management, the recognising unmet needs, signposting services and managing complex symptoms safely. There was a lot of cross-service and interspecialty teamwork, and part of that was around recognising dying and advanced care planning. And then there was a lot of involving and supporting carers. One of the unanticipated outcomes I've hinted at already, at the beginning of the project, we had a launch event, which was a fantastic event, actually. And Sir Alan came and was one of our esteemed speakers. But it was actually a fantastic opportunity to invite all of the stakeholders we were aware of in the region who were interested in transition, who were working with transition, to come together to highlight what we were setting out to do, but also to talk more broadly about where are the problems, what is the knowledge. And we were also delighted to hear some of the early outcomes from the transition research project that was done between Newcastle and Northumbria universities, and fantastic outcomes of that, which, while being really important, didn't particularly focus on these most complex needs patients. And so while it's been very, very useful to be able to extrapolate some of their findings to our group, we've also had to have in mind actually where is it different for our young people. Following on from this launch, there was a group of us representing different specialties who started to talk and started to meet and started to recognise that we were always copying each other into each other's letters for the patients that we were seeing. And we decided whether we wanted to formalise that a little bit more, and so created a regular cross-service multi-specialty team meeting, and that's across 2 hospital trusts and the hospice, with invitations to social workers and GPs as relevant as well. It's cross-specialty. We have regular attendance from the home ventilation team, the intensive care team, the PEG team, the neurology, neuro rehab, myself, and there are probably more, and the learning disability liaison team. I'm sure that some I've missed there. But what's fantastic is that we're able to sit down together, talk about particular patients who we are concerned about, who we feel that we're not sure where to go with, or want to make sure that we have some continuity with, and also learn from each other. And we've actually already done a regional teaching day around neurodisability, planning another one, I think, for this summer, and have really benefited from that peer support, from knowing that I can phone a friend if I need to, if I'm struggling and need to get a sleep study quickly, or need to have some clever epilepsy expert tell me what to do about managing status epilepticus at home, or something like that. It's actually been incredibly supportive and helpful. And I think if it is the one benefit that really gives me joy about this whole project, is that I feel that I'm part of a team now, rather than having that quite professional isolation that I'm sure many people working in transition experience. We've also been,
are you nearly done?
I am. I can. Yes, I'll finish this slide and then I'll skip ahead to the last one. Sorry.
Great, thank you. It's all right.
And I would say the only other thing to relate to that is that we've now been working very closely with the paediatric team to look at how we can actually build this multidisciplinary team into a part of a process for transition, so that young people are actually referred early to the team, so that they're being referred into a team, as well as the individual clinicians, to feel that continuity. I will skip ahead for the other things. I think it's already been mentioned that we are continuing the project, but as a consultant only lead here. And that's very much with me linking into the teams and still testing out the water as to where we go. So my overall reflections, this project has acted as a launch pad for our organisation to engage in a much wider way with transition within our region. We learned from the patients themselves and the families and local professionals, and we've adapted and continue to adapt in response. Networking has been a huge part of this. And I think overall, I think my reflection, even without COVID, that for us to really feel an impact of this and to see what's sustainable and what's going to work, we probably need at least 5 years, because it feels as if this is still building. And if we want to build it well, we don't want to rush it. That's my last slide. Thank you so much. And thank you so much to the funders as well.
Thank you very much. Sorry to rush you along, but we are...
My apologies.
No, it's not your problem. You know, we just need to move on. Gareth, are you here? Are you still here?
I am still here. Hi, everyone. Nice to see you all. Thanks, Joe, for that. That was insightful. So I'm Gareth Jones. I'm the fairly new in post CYP lead for the All Age programme in NHS England. So we're working on a specific amount of work against the long-term delivery plan. It's quite a dry presentation, apologies. I am a clinician by background, and it's just been so insightful to hear all the amazing work that's been going on over the last few years, and thank you for all the work that you're doing, and thank you Together for Short Lives for inviting me. And I think ultimately we know that the ICSs, the ICBs, all these acronyms are forming, and we want to make sure all of this is very much heard and spotlighted. In terms of some of the work that I've heard of today, I am more than happy to get some case studies together and present more formally and work with you, because I think that's really useful and insightful information that we need to share for children and families ultimately. So I've been asked to do a very, very brief update on what's going on nationally from an NHSE perspective around transition specifically. So this is very high level, but I hope it galvanises some of the conversations that have been had today. I'm sorry I can't perform miracles and say we've got lots of money, but what I can do is say that we are trying to influence children's palliative care greater and greater as best we can. So a couple of things. For those that might know, there is a service specification for children's palliative care that's been around since about 2018. That was refreshed and consulted on last year, so 2021, Together for Short Lives, and various partners up and down the country had their opportunity to feedback. As part of that, there were a few things that came out of it. One, that we need specific elements to bolster and strengthen that specification for CYP palliative care. Firstly, neonatal and perinatal care. We are seeing a huge amount of deaths within the first 28 days, and actually we need to focus our attention on that. Secondly, transition. As we're all here today, we need to talk about that too. We have been given permission, but I think part of the consultation process has been insightful in that many, many colleagues up and down the country said, well, what about transition, both in the service spec for CYP, but also in the adult one? We hope that they both will be aligned in terms of what we expect from an HSE for both adults and children. The adult spec is very different to the CYP, but we're going to align in terms of the transitional wording. However, what we really need to do is make sure that the spec is fit for purpose for transition. So we will be working with and strengthening that spec by adding some appendices, one around neonatal, which I'm not for here, but for around transition. So Lizzie Chambers and Davina Hartley. Davina is working with myself at the moment. She's a regional manager up in the Northeast. Are gathering at pace to work together to develop a specification, very high level, for children's palliative care and transition. be working with Louise Porter, who's just about to speak after. So the Burdett transition nurses will be working as part of that. Our CYP transformation nursing leads in the CYP transformation team at the NHSE, but also to make sure that we cross over into our adult world. We're inviting Hospice UK to come around the table to develop that piece of work. The outcome, of course, is to ensure that that 0 to 25 agenda is really fit for purpose for children with palliative care needs, and that we strengthen and influence our ability within these newly forming organisations up and down the country. So that's the first thing. The second thing about that specification, it's going to be the first specification that I know of. Alan, you might know more, but I think it's going to be the first specification that will be formally published on NHSE and I, which, as some of you might know, is quite a hard thing to do. So it's really pleasing that we're doing that. The second thing is a little bit about the CYP funding. So there's two things with that as part of the long-term commitments from the NHS plan. That's hospices and children and young people's match funding. So some of the match funding we have been using specifically over the last sort of 3 or 4 months to develop transitional services, very similar to how Together for Short Lives have published their evaluation today. There are 2 projects that are going on in the Midlands, developing pathways and toolkits for their local populations. And there's also a hospice up in the northwest that we're involved with as, in some respects, as an exemplar site for transition. And taking the elements that have been discussed really this morning, but with some specific NHSE and I funding around developing pathways, but also about working with adult hospice colleagues, so that there'll be a clear pathway with an identified coordinator, which we know, certainly from the discussion this morning, will hopefully affect and improve the care for those young people, but also ensuring that adult hospice is made very young people friendly. It was described to me the other day as, you know, a very beige hospice in somewhere in the northwest, and we're hoping that with using some of these funds will make it much more young people, a little bit like the teenage cancer work that's been done in some of the hospitals. So that's a very quick summary of what we're doing, and I hope that that spec work will actually really help support the work going forwards. I think I'm going to hand over to Louise now, who works with us on the transition, but more around SEND as well.
Okay,
Thank you.
Thank you very much. It's good to know that you're on the case and that we have an ally. So thank you. And off you go to whatever it is you're going to. Thank you.
Cheers. Thanks, everyone. Cheers, Louise.
Louise. Are you muted?
I think I'm unmuted now.
Oh, no, you're not on mute now. That's fine.
Thank you. I just had a pop-up message saying someone was going to unmute me, but it's worked. So thank you for inviting me. My name's Louise Porter and I'm lead nurse for Transition for England, and I'm funded by the Burdett Trust for Nursing. So I first came into contact with Together for Short Lives in actually 2015 and met Lizzie, David Strudley at the time, and Richard Watley, and was working with the Regional Action Group in Yorkshire and Humber. In my previous role, I was transition lead for Leeds Teaching Hospitals Trust. So during that time, I developed a quality improvement process for transition, and we got further funding from the Burdett Trust for Nursing to be able to roll that out across England to help all organisations improve transition pathways. So there's myself as national lead nurse and 4 regional nurse advisors who work across the whole of England. So they work in the 4 main regions of England. So that's the North, Midlands, London and the South. And we work with all organisations, like I've said, under the umbrellas of hospitals, community, GP, learning disabilities and hospices and palliative care and mental health as well. So it is a bit of a huge project. So the aim of our project was really to look at the current landscape of transition across the whole of England. So where is transition happening currently, in what services, and is it spread across whole organisations? But also to support organisations to work through this kind of formal quality improvement process to improve their transition pathways. But alongside that was working nationally to influence transition at a strategic level. So identifying what the main barriers were to transition from an England-wide perspective through all the organisations, and actually what could we do to help support influencing resolving some of those kind of challenges and barriers. So I have to say that the work, there's lots of crossover with Together for Short Lives, and it has just been brilliant listening to all the presentations this morning and looking at the evaluation as well, because a lot of those projects we will be able to share with people. So part of our role is actually just connecting people and letting them know what's out there, so what best practice is currently happening, so that people can learn from it. So I was very well aware of the GPs project, and we've been sharing that with lots of people already. And it's actually a great resource for people with training needs as well. So not just for GPs, but for other people that just wanting to do some e-learning around transition generally. So with the work that we've been doing from a strategic level, we've been working very closely, as Gareth says, with NHS England and NHS Improvement. And they have been absolutely brilliant. So we work with the Children and Young People's Transformation team and the policy team in particular. So Katie Pucklet and Michelle McLaughlin there. And we've highlighted some of the biggest barriers with transition being time, money, resource, environment, skills and training, and complex needs, or people with life-limiting conditions, the coordination of their care, IT systems that kind of don't match up or work well together, or they're not functioning in the way that we need them to for transition, and data collection. So as you can hear, lots of them will, you know, cross over into the work that you've already been doing and the work that's already highlighted by Lizzie this morning, just looking at some of those organisational kind of factors. And just looking at those lists of organisational factors, the things that I kind of noticed that we're definitely crossing over with the training skills, the champion role, coordination role, and securing senior buy-in as well. So that's very much embedded into the work that we're doing. So all of the work that's been done with Together for Short Lives is really providing evidence for us to say actually what we thought was happening is definitely happening, and we need to look at some solutions. So the solutions that we've been looking at with NHS England was, we started off with NHS Improvement and supporting a transition collaborative that was set up by Angela Horsley, who was head of Children and Young People at the time, subsequently has retired and is working with Hospice UK, so we've still got links there as well. We've been working on a framework for transition, so that's a national framework for transition, and then looking at the skills of staff. So there isn't formal training for transition out there that is equitable right across the organisation. So we've put together a capability framework. So it's a framework that basically identifies the skills and knowledge that staff need to have at all levels when caring for young people in general, but also including transition. So that hopefully will be launched towards the summer of this year. It's just taken a little while with COVID. Things are taking longer to get published through NHSE. So we're hoping the framework for transition and the capability framework will be out around summertime. And then we're looking at a training package. So a national training package, pulling together all the training that's already out there. So we'll be having conversations about whether we can use the Royal College of GPs e-learning as well within that. The other gaps were around inspection, governance, scrutiny and reporting, and definitely funding. So they're two pieces of work that we're looking at currently, and looking at how we would fund pathways. So I've been very interested listening to the economics presentation, and actually how much does it cost, because some of that will be you know, very useful to us when we're looking at actually how do we put a cost attached to a transition pathway for somebody who has a life-limiting condition or complex medical or physical needs. So we also have a research arm to our project as well, and we will be evaluating our work. We will be evaluating whether our quality improvement process works, but also what works under what conditions and by who. So where we've got organisations out there that might have a service that have got transition working brilliantly well, what elements of that mean that it works well? Is it down to a person? Is it down to a team? Or is it down to things that they've got available to them? So is it resources, is it environment as well? So looking at the functions really. So really, just in summary, what we're trying to do is look at direct help for staff within organisations, and making sure that those organisations have got exec buy-in at a high level, making sure that they've got champions for transition, or they've got a lead for transition. Working with those linked people to basically talk them through how to set up and formulate best practice pathways for their services within the organisations, but also then looking at the strategic levels, and actually looking at solutions that are long term and that will help people to implement these best practice pathways. Because where they are forming pathways, it's all very well having a pathway on a piece of paper in front of you, but if you haven't got the resource or the funding to be able to deliver that, then it is very, very difficult and could be seen as a bit pointless. So actually we need to solve some of those high level barriers to be able to put them in place as well. So I think really you know, that's all I've kind of got to add today, is just to say that if anybody does want any help or support, or you want to get in contact with me, I will put my email in the chat. If you want to get in touch with your regional nurse advisor specifically for help and support, or just linking up with other people, then if you email myself, I'll put you in touch with the correct regional nurse advisor for you.
Okay. To say that's all you have to say, it's an enormous amount. I mean, the most important thing is that Gareth and you are on this call. You're clearly part of this whole community trying to improve things for young people, you know, in transition. So it's just having you here is wonderful. And, you know, clearly you have heard a lot of what has been, clearly you've heard a lot of what this these various projects have done, and the important thing is that we get all the messages out of them and tailor them to the individual needs. You know, there ain't going to be one thing which solves everybody's problems, but the fact that we're all thinking together is excellent. Now, we've completely screwed up the question and answer session. We had 20 minutes, and I don't know where we've lost 20 minutes. We've only got 2 left. Lizzie, are there any key questions that we need answered? Lizzie.
There were some questions, but I'm not sure if we're going to be able to do them justice in 2 minutes. There was a question about equipment. There was a question about the idea of transition champions, and who takes those roles on. I don't know whether.
Well, I think the important thing is that is that we share these presentations today. We give links wherever possible for people to speak to the panelists, if that is okay. But I think we shouldn't drag this out. Although there's still 76 people here, that's wonderful. Thank you. Thank you. I mean, can I then just sum up? I think it's been a really good morning. I think that what this project, these projects and program have done is move transition to a higher level. We got lots of people all over the country who are now doing things that they would never have done before. We've heard today of projects which have been really successful and I think can be generalized. I've been watching the chat as it's come in. People have been very positive. So I think that we should probably call it a day here. It's lunchtime, and here everybody's saying, please do get in touch if you need any help. So we'll give contact details with the on wherever Lizzie is going to put them.
Yeah, we'll email everyone with links to the report, that kind of thing. Yeah, thank you.
And I think the important message for me is that we are all, I mean, one of my key words at the moment is belonging. Many of you will know I was involved in Scouts for a long time, and we asked 5,000 Scouts why Scouts were so successful. And the single word they came up with was belonging. And I think belonging is hugely important, belonging to an organization that has common goals, common needs, and where you can share things with people, because it stops the isolation of parents, stops the isolation of young people, and the isolation of staff. So this is a community that we're all belonging to, and I hope that these projects have moved us much more into a community. So thank you all very much for your time this morning. Thank you for all the presenters. Thank you once again to the funders. And thank you to Lizzie and Julia for putting this together. And the one person that's made it really work, you've never seen, he doesn't want to be seen, it's Guy. You know, Guy has masterminded the technology. And apart from me not doing the timekeeping very well, I think it's gone extremely well. So thank you all very much indeed, and enjoy the rest of your day, or take the rest of the day off, I don't mind.
And thank you, Sir Alan.
You're most welcome. Okay, thank you.
Thank you.